Alright folks, we are live coming to you Friday morning. Friday morning. How y'all doing this morning? Gonna throw a little shout out to us. So this old video I did, this is the snapping hip video that I have playing in the background here. And that's the kind of video I did, oh shoot. A while back. So, I'm just showing a little love out here. For some reason this person's not getting my subscription, even though I keep trying to do it. Hope you guys are all doing good this morning. I kind of changed my setup a little bit. Scully's farther away from me because he was irritating me last night. He wasn't being very nice. So, I have to do some social distancing between myself and Scully. What do we got in the channel? BET, Brown Eyed Truckers here. Good morning, my dear. How are you doing this morning? There we go. Hopefully that helps. Alright. Let's get out of my channel here. Is it just you and me, Brown Eye? VET? I still can't find you on Facebook. Can you find me, please? I can try, we'll see what happens. Hi, NH Gear 12, hi, how you doing? Oh, you're nice and new to the chat. Nice to see you here. Let's see here for a second. Oh, let me see, Facebook. I assume you mean FB, you mean Facebook, right? There you are. I found ya. I'll send you a message. There you go. Found ya. All right. How's everybody doing this fine, bright morning? I clear my garbage out here. Wow, I got a lot of it. I had done that this morning. Woo! I don't do that, boy. I got a lot of stuff on this phone. Oh, I got 3 washing right now. Here we go. Hopefully we'll get some more. I'm going to shout this out here for a second. Let's see. Share. Create a post. Here we go. Share me on Twitter. Tweeting. This is so easy to do that. Just boom, one button. And let's see what else. Facebook. Go. Okay, that's enough for now. All right. Come on now, phone. Whew, that was slow for a second. So, like I said last night, I thought a little bit about what I'm going to do on my next few videos, and I'm going to continue to do that, which is I'm going to do a series on the hip, and I'm going to start out with, you know, the what is snapping hip and the anatomy of snapping hip, and see how I do with that. That will kind of give me an idea of the type of content people want to see, whether it's just instructional, because that's what my first video is going to be, with obviously the comedy and stuff like that in it. And the next video I'm going to do is probably going to be home treatments for it, you know, and then we'll see how I do with that. And then the next one's going to be probably defining the different types a little bit more specifically, and then, you know, either the surgical component to it. So we'll see how it goes and see how many types of views I get. So that'll be interesting. I got 3 in the house right now. I shouted myself out. So this video, see if I can blow it up here a little bit better. There we go, that's better. So this video that I'm playing right now, this is when I started playing around with the ads. You know, having a call to action, as they call it, sign, which is the average Joe symbol. That never really worked for me at all. People, no one clicked on it anymore or any less, and so it's almost like, you know, when you see a stop sign and people end up just yielding it, they don't really stop. So I think the reality is those call to signs, I don't think they work. At least they don't work for me anyways. And then I started adding the subscriber symbol every once in a while in the actual video itself. I do that under my Adobe's After Effects, where I can change things within the video itself, and so I add that particular After Effect, which is subscribe to my channel, and I usually either opacity level, I change it out, or change the size of it and stuff like that, or change the color. And so every once in a while I see that works, but I haven't seen enough consistency with it. Excuse me, and I did that for a while, so I'm not sure what you guys think about the call to action, but I don't see it working very well for me. All right, I think I got you now, BET. All right. So, we got 4 in the house right now. Not certain who it is, but there's 3 or 4 people watching. So this video, or this live stream I should say, will turn into a video after I'm done live streaming it. I'm gonna do a little quasi, kind of talk about the video, talk about my upcoming show, and then talk about any type of the problems that people are having or answer any questions that people might have for this. We'll see how it goes. Oh, I got 3 in the house. Anyways, we'll see how it goes. So right now it's 9:30 in the morning, or 9:38 in Eastern Standard Time. And so this video really was the first video that I did from start to finish, having an intro, a middle, and an end. Having a starting graphic, as you can see, Average Joe PT. I've continued with that particular music and graphic, and I always show my disclaimer part so that people don't decide to just sue the pants off of me for no reason. This is kind of really the first I actually used a bottle too. So I was done doing this video and didn't think anything of it, and started to see some hits probably within the first probably 2 weeks. I had like 60 views on it, and I was like, what the heck? Like, wow, is it the model that I did? Is it the intro? Is it that I did it in succession, beginning, middle, and end? That I only did a 6-minute video? So I did so much at one point in one video that I really couldn't tell what did well for me and what did not. And I've traced back and figured out that it really was just the content. It was succinct. It was short. People like that with the model, at least for that particular problem, for the hip, the snapping hip. And it continues, like I said last night, it has legs. I looked at it, it has almost 1,500 views right now. It's my largest video right now. It's probably one of my oldest too that has the model and has the beginning, middle, and end. So for some reason that one just seems to have legs with it. Continues to go. So that's right. Yeah, now I can follow you and support you on any network. Well, that's nice. That's nice, BET. I appreciate that. Yes, I have also hat maker and her husband. Oh shoot. I can't remember the title of his show. He makes models and stuff like that. Anyways, they are supporting me something serious. Shout out to them, hat maker and her husband. I'll remember his. I'm gonna go out and find his actual channel so I can shout out to him. Let's see if I'm smart enough to find it. Oh shoot! And I don't know if I can find it here. I got a lot of them. And for some reason, I'm drawing a blank on him, but I know she's hat maker. And now let me go to her. A, B, C, D, E, F, G, H, I, J, K, L, M, N, O, P. All right, where are you, Runny? Oh. Come on, where is it? In the sea of things. Let's see if I can just type in. There she is, Ernie Hatmaker. So shout out to Miss Ernie Hatmaker. I love you, girl. Right there she is. Little Ernie Hatmaker. I'm going to zoom in so close that it's going to hit you all. So that's her. And I'm trying to find her hubby, because he's got his own channel. And I'm sorry, sir, I can't seem to find you. There he is. Ed's attention to detail. There he is. A shout out to Ed's attention to detail. That's right. I'm probably not even angling this correctly, but them two, they are awesome, just like BET is. True people. Oh, you just uploaded a new one, Brown Eye. I didn't see that. Gets stuck and blocks exit. Ooh, you didn't look happy there. I'll have to look at that one after the show here. Oh man, I got two in the house. We'll see how good it does this morning. It might be a slow morning. I've never done a live stream on Friday. I'm normally at work and had today off. And also I've been doing all my videos, dropping my shows on Saturday, so I've spent a lot of my Fridays just doing my videos and editing them and everything else. So now that I'm doing them on Saturday, so I'll probably spend probably this afternoon, most of Saturday, and probably part of Sunday editing the video and dropping it probably Sunday afternoon if I'm right. So this will be my last live stream for this week, which is Wednesday, Thursday, and Friday. I've never done 3 live streams in a row. But anyways, like I was saying, this video back here that I did, and it was a really clean video. You know, I said, all right, let me go ahead and this my template, and I've done this for quite a while now. Give a little bit of instruction, the anatomy, what I'm talking about, and then, you know, a little intro, go over the treatment techniques that you can do at home. Back then, when I did this old video, it wasn't on like pain control and pain management and different home treatments that you can do in regards to that. It was just instructional, an intro and instruction, anatomy-wise, and what's going on, and then actually doing the treatment. So it was more of an instructional-based video. There was no humor or comedy or, you know, the different characters that I have now, and so, and it did all right. And it continues to do all right. So, you know, I'm torn if my channel doesn't continue to do my views on my different shows, don't continue to do as well after I do this series of hip stuff, then, I mean, that might be a wake-up call to me that I need to change my format back to what I did back then. So this is going to be a real churning pot in my particular YouTube channel, and we'll see how it turns out, if truly all this extra work I put into the different characters, the Adobe After Effects, the editing, the color, the sound, the After Effects sounds, if that all makes a difference in how many people watch the video and how long they watch it for, or are they truly, for my niche, are they truly just looking at, you know, cut dry content? I'll find out here in the next probably month. Hi, Lady Z. How you doing? Nice to see you. Thanks for coming to my channel. I don't normally do live streams on Friday, Lady Z, but I figured I had the day off, and so I figured I'd do one. And I'm talking about, you know, the anatomy of the hip last night and tonight. My old video that I did that you see playing years ago, probably 4 months ago now. And essentially, I'm going to be doing a series of the hip over the next probably month and see how well my channel does in regards to that. So last night I talked about the hip pretty detailed. I mean, for my channel, for Average Joe, I didn't go into detail, which I could. Maybe I'll spice it up here since I got a little extra time, and this is my 3rd live stream for the week. Maybe I'll spice it up and really hit you in what kind of detail that's in a professional's head when it comes to looking at a pelvis and what we think of when we see this particular pelvis. So I got 4 in the house. Just listening here. I'm at work. Oh, Lady Z, thank you so much. Lady Z, what type of work do you do? How do you make the old-fashioned moolah? How do you make money? Maybe she's busy at work and she can't talk. That's okay. That makes sense. That's maybe the reason why she put that down. Okay, so let's look at it this way. So, when a physical therapist, at least from my point of view, I can't say any other professional because I don't have their mindset, but what we look at when, at least from a physical therapy point of view, when we look at least the anatomy of the actual hip, you just see ridges and bone, you know, of the bone and this giant piece of whatever. I work in a government hospital in Saudi. Oh, you're a dietitian. I didn't know you were a registered dietitian. Dang, girl, we need to do a connecting with an actual video you and I need to do. We could easily do a video together. You doing your dietitian part and me doing my physical therapy part. That would be an easy combination to collaborate with on a video, Lady Z. Let me put that down because that might be something I do on the side with you if you'd like. Lady Z is a registered dietitian, and we're gonna probably doing a video together. So that might be something we can get into there, Lady Z. That would be easy to do. At least from my end, I'm sure it would be easy on your end too. Anyways, and so when I look at the hip as a physical therapist, I look at this as initially symptoms wise. You know, if you're having pain in the hip, we have to rule out where the pain could be coming from. We have to think of is it mechanical or non-mechanical? Is your pain reproducible or not reproducible? Does your pain come and go? So that way we can look at it is this a systemic or an internal problem going on giving you hip symptoms, and I need to refer you back because it's not really in the realm of what a physical therapist should be working on. You know, is there a medication that you're taking that might be giving you some weird symptoms, and the side effect might be hip pain or bone pain or muscle pain? And so we have to look at that also to make sure that's not, you know, that's not a mechanical problem, and that you need to refer back to the doctor. That would be great. Yeah, that would be awesome, Lady Z. 5 in the house, and so so we look at that. You know, if you have a pain in this area, where is it being generated from? We're going to rule out the back really quick. We can do a few things to figure out if your symptoms are coming from there. Not only your discussion and you telling us, you know, when the pain started, how, you know, what makes it better, what makes it worse, but we also kind of rule out the back. There's a couple different techniques we can do to kind of make sure that your symptoms aren't coming from your spine. And then we look at, you know, the nerves and we look at the muscles, and we're figuring, are you having any nerve issues going on? You know, are you having numbness or burning issues going on that's more nerve related than it is, you know, muscle or joint related, or, you know, surgical related? If you're coming in post-surgical, is your symptoms classically from the surgery? So that's what when we look at the back, that's what, or excuse me, when we look at the hip, that's kind of some thoughts, streaming thoughts that we're going through when we look at the pelvis. Once we ruled out the back, then we start to look at the SI joint and make sure it's not coming from the SI joint. There's a couple different techniques wise that we can do. It's a cluster technique that we do really quickly. You know, 3 out of the 5 tests, that I've talked about this in the past. You do 3 of those 5 movements. I actually did that in a live stream probably like 6 or 7 weeks ago. ruling out the SI joint versus the lumbar spine versus just maybe piriformis syndrome, or if it's just you know, something that you've done to irritate a muscle group or a tendon. So there's a lot to go on when we look at a hip, not just the bone, not just muscles. We have to look at all these other things that's going on in our head at the exact same time. Kind of ruling things out, ruling things in. Now, did you have an x-ray done to make sure that, God forbid, there's not something else going on in here? Something as simple as, you know, could you have some sort of fracture that's going on here that's spontaneous because you have osteoporosis, or you have osteopenia, which is a precursor to osteoporosis? So that's another thought pattern. We've ruled out a lot of other things that I've talked about just a second here. Now, when we look at the muscles, when we look at the, you know, the ligaments, the tendons, and the muscles in this area, can any of them cause the type of pain that you're having? You know, sometimes that's not the case. It's not really muscles giving you pain as much as it is maybe you're having muscle weakness, and that's causing the joint itself to get irritated, or the positions you're putting yourself in a lot that's caused muscle weakness, that's caused the joint to get irritated. So there can be some confounding other issues going on, kind of like a domino effect, that's causing your pain to be generated in this area. Sometimes it could be referral pain, like I said, coming from the back going into the hip area, or the SI joint coming into the hip area. You know, you could have Shirley-Sarman muscle imbalance, where you have the tight iliopsoas, which is I'm talking about here in the very beginning of my old video where I show the green band, and that's causing, you know, some rotational components of the spine, are causing the hip to pull forwards or backwards, as well as your quadratus labrum muscle that kind of runs from the top of the pelvis here to the lumbar spine and the lower ribs that come across. And so is that giving you like a hip hiking thing and doing a you know, tug of war balance between the muscles in the front and the muscles in the back? So is there a muscle imbalance going on, a Shirley-Sarman kind of thought pattern, or functional movement strain, with an FMS kind of pattern that's going on in the pelvic area? There's a lot of things that can go on in this pelvis area. 6 in the house, give me a thumbs up or thumbs down. Hopefully it's a thumbs up. Gonna give myself a thumbs up. Why not, right? And so that's just talking about the pelvis. And so when we look at this, or the inanimate on this side, and someone's having pain in this area, there's a lot of different things that the physical therapist has to rule out. You don't even get the prescription. Like, we'll get a prescription from the primary care doctor. It just says hip pain. That didn't tell us anything. You might as well just blow your nose with that, because that's not telling us anything, which is fine. We're professionals. We evaluate and treat. We have what they call autonomy of practice, which basically means you could come off the street and we can evaluate you and treat you, you know, without needing a physician anymore. Though we do like to collaborate with them, because they see it's always to have, like I always say in my newer videos, it's better to have 2 heads is better than 1. It's always better to have a couple of sets of eyes on you instead of just, you know, the physical therapist. So I'm always happy to have the MD in, because obviously they have a lot more experience and education, but their education is in a different view. It's not, you know, I'd like to, it's, you know, in some ways, you know, they have this whole pecking order, you know. Yeah, are they their training is different. They are more the medical based, you know, ruling things out from an internal or the medicine aspect of it that the physical therapist doesn't get. But, you know, I don't want to talk out of place, but the reality is if we're talking specifically about a primary care doctor, me as a physical therapist, with my experience as well as my education, I actually have a lot more to bring to the table when it comes to an orthopedic problem, or a muscle imbalance, or a joint ortho problem, than your primary care doctor does. That's the MD. The PA, yeah, I have a lot more. And nurse practitioner, I have a lot more to bring to or as a physical therapist. I know it's to toot my own horn, but as a physical therapist, we have a lot more to bring to the table than those particular professions do. Now, a doctor of osteopath, absolutely not. They blow us out of the water when it comes to that. A physiatrist, maybe. It's hard to tell because they are kind of the back in the day where the kind of the tier. They are an MD. They kind of ran the rehab kind of departments the physiatrist did. So they're kind of a specialty of MD. 6 in the house. If you're an orthopedic surgeon, that's no brainer. But they specialize usually in one joint, or a couple joints. You have a orthopedic surgeon that specializes just in the shoulder, and that's all they do all day long: shoulder, shoulder, shoulder. And so the physician assistant that works with them, that's all they really know. I mean, I didn't say that's all they know, but that's what they specialize in. Obviously, they know everything else, but they're not. If you see an orthopedic specialist for the shoulder, they're not going to work on your spine. Anyways, I wouldn't. If I'm going to go to see an orthopedic surgeon for a shoulder, I'm not going to see him for his shoulder. I'm not going to see him for his spine. If I'm seeing orthopedic for a spine, and that's what they specialize in, I'm not going to go to them for a shoulder problem. So that's kind of the gist for that. And same idea with a neurosurgeon. You know, you have a neurosurgeon that works on the spine, and you also have them that work on the brain itself, the parts of the brain. And that's when the two professions kind of mix together, orthopedic surgeon and neurosurgeons. They both work on the same spine. Kind of like an occupational therapist and a physical therapist. They can kind of combine sometimes, and they can both work on the shoulder, or they both work on the hand, wrist, and elbow. But you don't see an occupational therapist working on the spine. If you ever see an occupational therapist working on the spine, leave. They have no specialty, should not be specializing in the spine if you're an occupational therapist. Same idea. If you see an orthopedic surgeon and they're trying to tinker with your brain, you better leave because you're probably not going to do too well. Pause and effect. Meant to be RVing. Thanks for coming. B&D Crafts. Thanks for coming. Scott Jacobs of In Appreciation. Thanks for coming. Much love. It's about time now. Thanks for coming. Much love to you all. I got 9 in the house right now. So today I'm talking about the pelvis. My old video back there that you see it is an old video that I did about 4 months ago on the hip. My next 4 videos are going to be a series videos about the hip and snapping hip problems. There's 3 kinds of snapping hip that I went over last night in my live stream. That's going to be my first show on Saturday. And then my next show is going to be the following Sunday is going to be on the treatment techniques for the snapping hip. And then the next Sunday after that is going to be the types of surgeries that you can have for snapping hip. And so stay tuned for those. I'm going to do a series now and see how that works out with my snapping hip syndrome. Had to work, but wanted to give you some support for the great info you share. Thank you, Pause and Effect. I'll be over to your place. I love you much. Pause and Effect raid. Oh, this was a raid? What? This is my first raid. Pause and Effect. Much love. First raid and Average Joe PT. That's right. I've been doing this since November. Pretty cool. First raid for me. I can now say I've been rated as a channel. So, thank you. Much love to you. So, this hip problem that I talked about last night, snapping hip, you can get it. It's called runner's hip, dancer's hip. You kind of get this kind of click every once in a while when you rotate out or rotate in. It can be painful. There's 3 reasons why you can have that. there's one muscle group runs down. Whoops. Oh, Siri, this thing never usually works when I want it to. So there's two muscles, excuse me. One runs the top of the spine here, the lumbar spine runs all the way down. It combines with the other muscle, the iliac muscle inside here. They make this iliopsoas then as one muscle group becomes a tendon and wraps underneath the hip here. And so, in front of the hip here, excuse me. And so it's a major hip flexor muscle. It can snap. That muscle, there's a eminence here where that tendon can snap over that area or snap over this bone prominence here and give you like a vibrating shooting pain. That's one. You can have the other clicking or snapping is from the iliotibial band, and that runs basically from the top of your hip all the way down and crosses your knee joint. And so if we look at the knee here for a second, from the outside it crosses that knee joint and attaches down here around the fibular head, which is that little bone on the outside of your knee. And so that has two main muscle groups that attach to it. It's got the glute muscle here on the side, which makes up three muscle groups, as well as the TFL, or tensor fascia lata. And so you can get strumming from that IT band and start clicking over what we call the greater tuberosity, which is this bone off here on the side. And that can give you some serious pain, especially if it's repetitive, if you're a runner or a dancer, or if you're standing up and sitting down a lot, or maybe you're getting on and off a forklift a lot the same way, or getting in and out of a truck, a tall area a lot, on and off a ladder. There's all types of instances that you can get this snapping hip, not just from a runner or a dancer. That's just what it was commonly seen back in the day when they first started looking at this particular problem. And so, woohoo! BET's in the house. Show some love to her if you all would. That would be nice. As well as Lady Z. She's at work right now and she's just listening. So that is the second way you can actually get the snapping hip syndrome, that snapping, popping, clicking in that pain within that groin area and off to the lateral side of the hip. Let's move this out of the way so you guys have a better view of it. The other one is the labrum. And so I talked a little bit about this last night. Let's take this off for a second again. And if I take this out, your hip itself has a thing called the labrum. And that labrum essentially is the outer rim of the socket. And that kind of gives a little bit more depth to the socket so that the head has a little bit more coverage and also a little bit more movement. Now, that labrum is a ligament type tissue and it can tear and fray over time. And if that ball hits that ligament in there and catches, if it tears and pinches, you're going to get pain, deep pain in that groin area. And so that isn't going to feel good. What they do with that, like I said last night, they'll do an MRI with contrast dye, where they will inject dye into the joint area. They'll send you in for an MRI, and then that cadmium type contrast will light that area up, and next thing you know, they can see that tear if that's where your symptoms are coming from. Now you can have what we call an asymptomatic tear, and that's what I talked about last night on my live stream, where you can have a false positive on the MRI with the tear, and it doesn't really exist. You know, your pain isn't coming from there. It could be coming from the snapping hip of the iliopsoas from over here, or the iliotibial band off the side, snapping on this greater tuberosity bone. And so the doctor might just give you a steroid lidocaine injection into the hip here to stop the inflammation from occurring, and lo and behold, your pain goes away, and you don't need to have surgery to fix the labrum. Cross your fingers on that one. Now there's also, not snapping hip, But another, what I call the runny nose syndrome, a lot of things cause a runny nose. A lot of things can cause deep groin pain. Now, it doesn't have to be snapping hip. You hope it is, because that can be an easier, quicker fix, especially if you see my playlist, as well as this video back here that went over some exercises that you can do for basic snapping hip syndrome. But you can have osteoarthritis, OA, in the hip, in the ball here, and that can give you the same kind of deep groin pain. And you can get that osteoarthritis in your 30s and 40s, especially if you haven't been good to your body, and that can cause a lot of your problems. They do an x-ray, they're like, uh-oh, this person's got a really worn out ball and socket. We're probably going to see if we can either do some therapy, or if you're old enough in your 40s, they might talk about doing a hip replacement at that point. Even though you're only in your 40s, I've seen it myself, and it's becoming more and more prevalent of people in their mid to late 40s getting hip replacements, because the hardware lasts so much longer than it did 10 years ago, and so they don't have to make people suffer as long waiting for them to get older so that they don't outlive the hardware too long. Got 10 in the house. Hey David, David Centino is in the house. I saw your last video, Dave. I watched it this morning. Really good, like always. That camera would have drove me nuts though, Dave. No stabilization. I mean, I have a hard time when I do the kind of the B-roll vlog and in my last couple of videos. I'm trying to hold my arm steady, and I know this phone has a little bit of stabilization on it. I can't imagine. And my camera, you know, you're going along, the thing, it loses its focus or it doesn't stabilize. That would, oh God, that'd drive me nuts. Dave's waving hi to me. And so that's another way that you can have that inner hip pain. The next one simply could be is you have avascular necrosis. You have an AVN where you have that deep pain all the time, and what's happened is you lost the artery here where the head comes onto the what we call the acetabulum area here, and so that attaches right in on the acetabulum, right in the center, and that blood flow going right to the head of the femur bone here, and if it gets sheared, or unfortunately it happens as any disruption to this artery, the head dies. No blood flow, no oxygen, death. And so this thing will start to give you deep pain, and in a very short period of time, you'll start to have fractures because it's dead. So that's avascular necrosis, or AVN, and that's, you're going to have the hip replacement. There's no way around that. So that's another reason why you might have some deep groin pain. The other one, Ladybug is saying, Lady Z is saying, hi to all there. Dave's saying, Lady Z, hi. It's 11 in the house right now on me. The third one that people don't think of when they talk about you having that groin type deep groin pain in this area here is it's actually coming from your lumbar spine. It's coming from your lower back. And so you can get a lot of referral symptoms from either your facet joint or a muscle group, or God forbid the nerve coming from maybe a pinched nerve or an inflamed nerve. And this thing always fights with me because it's got glue on the end of it so it doesn't fray. There we go. And so you can have, coming from your lumbar spine here, anywhere along probably, I would dare say, from L4 down to S1, if you're having any type of irritation within the joint space, these facet joints that I talk about all the time, you have any arthritis or irritation in there causing inflammation around the nerve, or just referral pain, not radicular pain. Talk about referral pain right now, which is different than radicular pain. And that can give you pain in the groin. It's actually coming from your lumbar spine. And so there's a lot of things that you can get your symptoms in your groin area, and hopefully if you have a decent enough physician or a good enough physical therapist, they can really rule out whether your symptoms are actually coming from your lumbar spine or your hip. So it's very easy to lose sight of where your pain's coming from if you're having referral pain, and the referral pain is much stronger than the origin site. And so you got to be mindful of that particular issue. Now, if it's coming from the lumbar spine, if you look at a couple of my older lumbar videos, the disc one, the stenosis one, under my back playlist, it goes over those particular type of treatments where your pain's coming from the lumbar spine, but you're getting symptoms in your groin area. If you do a couple of those different techniques in those particular videos and your symptoms seem to go away, then you're having a lumbar spine issue. And I would say go ahead and either follow those playlists or see your primary care doctor and say, hey, I've looked on Average Joe. Obviously don't say that. You say, hey, I started lying on my stomach and doing some of these different exercises, and the pain in my groin went away, and now I'm having more just lower back pain and no more groin pain. That's actually a positive sign. Your symptoms are getting better, and you found out where your problem is coming from. It's not coming from your groin hip area. It's coming from your lumbar spine. That's a huge one. Another one I see misled a lot over the years is a combination of carpal tunnel syndrome or numbness in these couple fingers here. The whole nerve coming through the wrist. And if my brother from another mother, Matt Velliker, gets me or sells me the skeleton, I'll have an actual wrist and hand and elbow. So I could show this besides just showing my hand. But I did a video way back, probably almost as old as this video that you're seeing behind me being played, where I talk about carpal tunnel syndrome and different treatment techniques that you can do at home to reduce your carpal tunnel symptoms. The median nerve, which is one of the nerves in your wrist and hand, gets compressed between the bones of your wrist, are called the carpal bones. Think of that as the floor. The median nerve is running atop of the floor, and you have this ligament running over the top of the nerve, and that ligament gets thick over time for repetitive use, and it can start to push down on that nerve between the floor of the bones and the ligament. Next thing you know, you're getting nerve issues. Now, that's one problem, but I've seen that being misdiagnosed, and it's actually your problem's coming from your neck. People might say, oh, they might have full neck motion but have some neck pain, but when they go to the primary care doctor, they're talking about all this wrist-hand numbness, and come to find out, they come to see a therapist, and they're saying they're having numbness in their fingers, and you check the neck, and the reality is you start doing some different tests that we do in the neck, like the Sperling sign, which is where you rotate and turn the head back, and you give overpressure, and what that does is it starts to compress the nerve on the one side of the body, and if you start having more symptoms in your hand, lo and behold, your symptoms are coming from your neck, giving you symptoms all the way down in your hand. Now, you could have a double crush injury, what they call, where you have impingement from multiple spots. I mean, you could have a neck and a wrist problem. This is true. In that case, you would have to have what's called a nerve conduction velocity test, where they would test the speed of the nerve, hence the median nerve, coming from your neck all the way down into your hand, and they would really see where you're actually having the loss of signal or speed of that nerve, and then they could rule out whether it's really just from your wrist, or it's coming from your neck, or coming from your neck and your wrist, or in your elbow. So that's a thing that they could do to figure out, really, is it truly carpal tunnel, or am I having a neck problem? The other huge one I see is if you're having a shoulder limitation, where you don't have full shoulder motion, and you're seeing a therapist, or you're seeing an orthopedic doctor, or hopefully initially you're probably seeing your primary care doctor, and you're talking about all the shoulder pain that you're having and the lack of shoulder motion, and so you come and see the therapist, or they do an x-ray, hopefully they do an x-ray, your primary care doctor does an x-ray, and say, yeah, you don't really have, the x-ray didn't really show anything, no fractures or anything, I'm going to send you to therapy. And so I get this prescription, or the physical therapist gets the prescription, and just says shoulder pain, evaluate and treat, and we're looking at it and like, yeah, okay, they got no motion there, or limited motion, and it hurts. And what you're supposed to do is you're supposed to rule out above and below the injury site. That's like physical therapy 101. If you're an evaluator and you're a physical therapist or a physician or physician assistant or nurse practitioner, I would assume, since I'm not them, they were trained the same way, and you're supposed to assess above and below the injured site or the pain site. In this case, if we're talking about a shoulder problem, you're supposed to assess the neck also. And the reality is a lot of times it's not. And so you can have an impingement of the nerve at C5 and C6 affecting shoulder range of motion if it's bad enough. And so if you have an impingement in your neck, the nerve is being pinched, whether it's a disc or whether you have stenosis in the canal, when the nerve comes out through, see that little nerve, that little hole? Right, if you have a bad disc or you have a really degenerative disc and it's squishing down and you see how that canal becomes really small for that nerve to come out versus a nice big canal, that can pinch on that nerve. And if it pinches hard enough, long enough, you can start to affect shoulder range of motion. The reality is your symptoms are coming from your neck and not from your shoulder. And we always, can't treat the shoulder if your problems are coming from your neck. So there's lots of different reasons why we look at other parts of the body, because it's the runny nose syndrome, I call it. That's not really a syndrome, I've made it up. But it seems to work quite well. People understand it, that a lot of things cause a runny nose. A lot of things can cause shoulder problems and range of motion problems or strength problems in your arm. And it's not coming from your shoulder, it's coming from your neck. Or if you're having wrist and hand symptoms, it could be coming from your neck, shoulder, or elbow. Same thing when I talked about in the beginning. Excuse me. You could have deep groin issues, and it actually could be coming from one of those things that I talked about in the beginning. The snapping hip, the avascular necrosis, the labral tear, or it can be coming from your spine referring into the groin area. So, make sure, whoops, oh, it fell off. Did anybody see where that bounced at? Ooh, that bounced pretty far. Oh no. Oh, I found it. I found part of it anyways. That probably bounced a million miles. I found the top of the screw. I found the top of the screw, but I didn't find anything else. I'll have to look for it later. Oh boy. I guess that's what I get for taking it off too much. But anyways, and this was not a very expensive model because it was very small. But for its size, it was expensive. That makes any sense because it shows a lot of great detail. It shows the disc, it shows the nerves, and the ball and socket and stuff like that. Give me a thumbs up or a thumbs down if you're still here. Thank you so much for coming. I'm going to go ahead and reset here for a second because a lot of times if I don't reset, this particular YouTube for some reason doesn't like to refresh. I got 8 in the house right now. Yeah. So I found the really tiny screw. I gotta find. Oh, there it is. It was still left on top. All right. So we'll put this back together here, if I can. I don't want to tighten it down too much because it's just really tiny, cheap threads on this, and it probably would strip them. I probably should epoxy this, at least the threads, and so it won't come back off, because I would never take this little model apart. But anyways, I always have a screw loose. Oh, David, no, don't say it isn't so, David. So there's lots of different reasons why you can have pain in one spot and it's actually coming from somewhere else. Now, those are all some of the different examples. Some of the ones that you've heard of, I'm sure you have, is if you have back pain, sometimes it might be a kidney stone. You have excruciating back pain and it's not actually coming from your lumbar spine. You're actually having kidney pain because your kidneys are on this side of your body. And so if you come to hopefully your medical doctors figure this out and you'll never see the physical therapist because that's a medical, not a physical therapist type treatment plan. But who knows, if you just go off the street and you don't see a primary care doctor and you just go see the physical therapist, which is completely legal because we have direct access, we have autonomy of practice. So as a physical therapist, you got to make sure that this person that's coming to you for back pain isn't just kidney problems. Or, the God forbid that, you have an indigestion, metal type taste, pain down your arm a little bit, you've had some lightheadedness, you haven't been feeling really good, your blood pressure's kind of wacky, and you're having you come in for shoulder pain, and the reality is you're having signs and symptoms of a heart attack. You can have signs and symptoms a couple weeks before you actually have the heart attack event. And so as a physical therapist, being the doctor of physical therapy, this is what we have to think of. We don't, I don't talk about this on a daily basis with my colleagues and stuff like that, but that's how we're trained in physical therapy. That's the reason why we have a doctorate degree, is because we think of this other side. This is the reason why it's 7.5 years of schooling and how physical therapy as a profession has developed over the years. When it was a bachelor's degree, you never got that kind of training because you never had direct access. You didn't have autonomy of practice. They saw a physician first, then they came and saw you, and you just saw them for an orthopedic problem. You didn't have to think about any of these other aspects that it's more of a primary care doctor thought process, but that's how we're trained nowadays. 10. I got a Aunt Kenny, got my mom in the house. She's got some thumbs up for me. That's right, thumbs up. 9 in the house. Had 10 in the house for a second there. If anybody wants to give me a shout out, I would love it. I would very much appreciate it. Oh, I got 8 in the house right now. 9 or probably 8 in the house. I always forget. I'm also online, and it looks at me as an actual viewer too, which is, I guess it's okay. I'm getting one extra viewer. In reality, it's just me. So, first of all, thank you for coming to my channel. If you haven't been here before, please subscribe. Scully and I would love to have you subscribe and hit the bell. If I'm not in your channel, subscribe. I will hopefully be at the end of this. I'll get back to you all. I had a raid that came in earlier from another wonderful group. Excuse me. I probably need more coffee. And so I got a bunch of people from that. That was my first raid ever. That was very cool. And that goes to show you that certain times of the day, I've never been on a Friday morning at this time of the day. I'm normally at work, and so the days I'm off of work, or when I get off of work in the evening, everybody else is on, and so a lot of times I get lost in the blur probably. And I've also never done live streams on Friday too, whether it was the morning, the afternoon, and so the reality is I might have to start getting up early a few nights or a few mornings and do some live streams at like maybe 2 or 3 o'clock in the morning, and see what happens then. It's not fun, but I might actually try that a few nights and see what happens. Okay, and so that was some different. If you guys have any questions, go ahead, just throw them down comments wise. I'll try and answer them. So that's some different types of referral symptoms in parts of our body that we can have, and they're actually coming from somewhere else. So That's the reason why, as a physical therapist, when you come to us and you guys say, oh yeah, the pain's here, or the pain's here, or the pain's wherever you're pointing at, and you're like, well, no, that, in this case, let's talk about the knee for a second, because I haven't yet. You're like, oh no, the pain's on the side of my knee, or the pain's on the inside of my knee, and I'm like, well, the pain might be coming from somewhere else. It might not be coming from that particular part of the body. Now, it might be, but we have to rule a bunch of other things out that you might have in pain in that area. First thing people think of is, if you're older, you're thinking the osteoarthritis in the knee. Other people might think that, they've torn something. Usually, if it's non-trauma based, I love you, but I won't be up at 2 or 3 in the morning. Oh, come on. Hey, Joe, I got to go, but I'll let this play. Great to see you. Thanks, David, so much. Much love to you, brother. Have fun out there in Cali. Yeah, that's right. David's out in California. I always say California has 5 seasons. And you might scratch your head and like, is Average Joe, is Scully, hey, is he got a screw loose? There's not 5 seasons. Never known there's there's 4, right? No, California has 5 seasons. The 5th season is called fire season. Because as far as I know, every single year, that place is on fire. So it definitely has a 5th season as far as I'm concerned, fire season. They have a mudslide season. They have an earthquake season. They have a drought season. I mean, California is coming up with new seasons every year. Alright, so I have 8 in the house right now. This is awesome. So let me get back to the knee here for a second. If you have any more questions about the hip or anything like that, I kind of went over it between last night and today pretty good. I didn't go over specific muscle groups that might cause problems. I did go over, some tendon issues. We could go over a couple other things if you want to. I'll probably be going over that in some of my shows that I do for the hip over the next month, so stay tuned for those. Pause and effect. Hello, Abronic. Sorry, I was away for a quick workout. Pause and effect. That's perfectly fine. Thanks for coming to my live stream. Thanks for rating. That was very awesome. I have 9 in the house right now. And so let's talk about, so if you have any other questions about the spine or the hip, I'm going to go, or the ball and socket, go ahead and throw them out, but I'm going to move on to the knee for a little bit. So I really don't talk about the knee a lot, and I don't talk about the ankle and foot a lot. I know I need to talk about that because a lot of people have knee problems. A lot of people have foot problems as well as the spine and the pelvis and the hip, as well as, sorry Scully, I'm going to move you out for a second, as well as the shoulder, or the shoulder girdle complex is what these 3 bones are made up of as a group. And so if we talk about the knee for a second here, there's really, this knee joint is a hinge joint. Let me just get my words out there. It is a hinge joint, hinge on a joint, like on a door. But there's also some rotational components to this knee. So there has some rotational components. And the reality is, if you're in a rotational component, when you get hurt, you're in trouble. Because the joint is more stable when you're straight on, or when you're in a squatted position, like this, than you are with a rotational component. That's because of how the menisci are on the shelf of the tibia, or the shin bone, or what we call the plateau. The shelf or the plateau is technically what we call the end of the tibia. And sitting on that shelf or the plateau are those menisci. And those menisci, they're really designed for a few things. And I'm going to kind of show you here with my silly little model with some tissue paper kind of wadded up. Now those menisci they're designed for a few things. Their main design is to allow the what we call the articulation, or the union of the knuckles of your thigh bone or femur to the top of the tibia or the plateau or the shelf. We're going to call it the plateau because that's technically what we call it. And so those menisci, there's two of them. They're kind of half moon shaped, and they're not even the same shape. So they are kind of weird, kind of angled type units, and that's because the knuckles of your femur bone at the end aren't straight on. They're kind of shifted off a little bit. And so this menisci really allow these two bones to meet with one another. And those menisci are kind of floating on there. They're not glued to the top of the tibia. They kind of have a little bit of movement so that your knee can flex forwards and back and rotate a little bit. And there's a membrane on the outside of your menisci on the shelf that kind of helps border everything in. And they help this menisci help displace the weight evenly through these two joints. And so they take on a lot of stress, those two menisci do. As well as your hamstrings on the back side. So now we're going to pretend that this tissue is a hamstring. All right, your hamstrings cross the knee joint, and so they go from your pelvis your ischial tuberosity here, your ischiums here that we talked about last night, and they cross that knee joint all the way down, and they basically flex your knee or bend your knee. And so you bend your knee in this direction with your hamstrings. People don't realize this if you are very good with anatomy. Your hamstring muscles actually attach to the menisci on the back side. And so as you flex your knee and extend your knee, it allows those menisci to glide forwards and backwards on the tibial shelf or plateau. And if you have a tear in there, now you're wondering why when I flex or bend my knee, people think it's just coming from the front end, and the reality they don't think of the hamstrings pulling the menisci forwards and backwards on the back side. Have to do the real job now. See you on the next slide. Thank you, Pause and Effect. You're probably gone already. Much love to you. I got to go to my real job. Yes, you got to make the dough. If you're not flexed off, or take the day off like I did today. And so, these menisci have many reasons why they are shaped the way they are, what they actually do, and when they get thinned out or fray, you have a problem, because that starts to change just like the disc. When your disc gets older and gets flattened down, it starts to change the mechanics of the joint and how it moves on the backside. It's the same way as when your menisci fray or thin down after years of work or overweight, and that 1-to-4 ratio, for every one pound you're overweight, it's 4 pounds of pressure on your knees. You're starting to flatten out that menisci. You start to change the forces of the femur on the shelf of the tibia or the plateau, and you can have wearing of the joint that way, as well as it starts to change the mechanics of how your kneecap moves on your femur. And so you can have what we call patella femoral syndrome, where your kneecap is not moving correctly, whether it's through muscle imbalance, something's too tight, something's too weak, something's too elongated, something's too shortened. You could have that issue. You could have an inflammatory process. You could have a bursa issue. There's lots of bursa around the knee joint. And so there's a lot of issues that can happen within that knee joint. Oh, I'm getting a drop off. I got 7 in the house right now, or 6. Actually, I probably got I got Dave who's just playing his in the background. Oh, I got 8 in the house. I'm mistaken. See, that's what happens. Any questions so far on the knee? There's lots of stuff we can go. Yeah.
I couldn't hear what you said.
That's because I didn't talk to you, Siri. It's funny how when you turn and talk to it, see how it doesn't do it every time? Crazy how this wristwatch is inconsistent every once in a while. Anyways, so talking about the menisci, gotta go, Joe. I have a call. Return now. Thank you, Lady Z, for coming. See you again. Thank you. Much love. And so when we talk about the patellofemoral syndrome, that's a whole other thing where you can have a tilt of your kneecap. What we call, you can have patella alta, you can have frog eyes, you can have winking patella, which is the angle of how your kneecap is, and it's being caused by muscle imbalance and tightness and weakness affecting that knee and giving you a lot of knee pain. You can have Pes Anserine, which is a classic, the 3 tendons that come across this knee joint on the inside, and that can get inflamed. Pes Anserine is Latin for goosefoot, which basically means the 3 tendons coming down this area they thought looks like a goose's foot. And so that would be the semitendinosus, the gracilis, and the sartorius. Those are the 3 tendons that cross that knee joint down here and make that thing up, and you can get a lot of tendonitis and bursitis in this particular part of your knee area, and that can give you a lot of problems. I'm going to go get a drink. I'll be right back. If you have any questions about the knee or the pelvis area, go ahead and throw it in the comment section. I'll be right back. All right, I'm back. Can I get myself a cup of coffee? All right, thanks for waiting for me. Woo! You guys dropped off like a rock. Wow. Yeah, where did I go, right? They all left. That's fine. They came for a while, and that was awesome. Oh, I got no questions, it looks like here. Not me. No, BET, you're solid as a rock, girl. You're still here. Did you have to work today, Brown Eye Trucker? Did you have to work? Oh, wow, you had to spend money. Wow, that's tough. You didn't work and you had to spend money fixing the thing. You don't think of like, I'm sure as myself being ignorant, I don't, if you think about, just being a truck driver, you don't think about all the maintenance and the repairs that you have to do to keep doing what you're doing. I never think of it, until you're in it, then you realize it. Oh, Coach Jeff, how you doing? How you doing? Nice to see you. Chevette, you missed it. I had a raid. I had like 11 people here, 12 people at one point. It was pretty cool. I had a bunch of people here. It was awesome. Talking about the knee, I've talked about the spine and the hip. If you have any questions, go ahead and shout them out. I'm going to talk about the knee a little bit more. If you guys have any questions about that. So I talked about the meniscus, these moon-shaped kind of cartilage that really make the femur or your thigh bone and your tibia or your shin bone work together, because the two bones aren't shaped the same way. They're irregularly shaped, they call it, and those menisci allow your thigh bone and your shin bone to actually work together. Oh wow, that excellent. Gonna make a video about it too. Oh, okay, that's a good idea. Yeah, you might as well do it that way. You're like, hey, because the trials and tribulations of being a truck driver. There you go. That's an idea. That could be jeepers, 5 or 6 videos. The injuries of being a truck driver. The crazy people that drive in front of you when you're trying to drive your truck. The terrible accidents that truck drivers have. I mean, you could have it as a title of Trials and Tribulations of Being a Truck Driver, and then you could have all the crazy things that happen while you're being a truck driver. Just a thought. I have no idea. Oh, I haven't seen that one when the truck got stuck. That's probably the latest one. I hadn't seen. The last one I saw was where it was all muddy, and that was the video that I saw. So I got to go see her newer video. But also the menisci. So I'm going to kind of show you on this little tissue paper. As we age, they start to literally thin out and be more flat. And so if you have something that's flat on a knuckle, you can see how you start to get a lot more movement in your knee joint, and can cause a lot more inflammation and pain and wearing of the cartilage on the surfaces of the bones when this menisci becomes flat and thinned or worn down further. And you can have it where you completely disintegrate the meniscus over time. It literally is bone on bone. The meniscus are gone. You're like, where the heck did they go? Well, that's a good question. Does anybody have any idea? Now, this could be a tough question for you all. Yeah, it came out the same time you went live. Oh, okay. I'll watch it afterwards. That's probably why I didn't see it. Guy blocked everyone off. Wow. That'd be a cool video to see. Anyways, and so, do you guys have any idea what happens when when they say, yeah, I'm bone on bone? Well, how the heck is that possible? You have a meniscus there, right? No, it thins out over time and starts disintegrating and worn away. Do you guys have any idea where the heck did the meniscus go? I fell in behind. Okay. All right. This is a hard one, anyways. There's a process in our body where if your body recognizes something foreign and not supposed to be in that area, there's a process where your body brings these cells in, and they start to take that away, and they break that down and take it away. Part of your immune system. This process is called phagocytosis, and that's with a PH. PH, phagocytosis. And that phagocytosis is the body's way of taking foreign objects away from the body. And so when your meniscus starts to fray or thin off or start to break apart, and it's just kind of floating, a little pieces floating in there, your body starts to break that down and take it away. Next thing you know, your meniscus go away. And that's not good. And so the same thing can happen with a disc. Let's say that you have a disc bulge, goes into a herniation, goes into a rupture or sequela, and then goes into fragmentation where a part of the disc breaks off and it's just floating inside the canal. We call fragmentation. Hopefully it's small enough that it's not beating on the nerve and just killing you, and with that, in that way you have to have surgery. And what happens is the body will do that process in there, saying, hey, there's a foreign object inside this area and it doesn't belong there. That process will take place and take that part of that disc and chew it up and break it down and get rid of it. And so next thing you know, it's gone, but that part of the, and hopefully your part of the disc that scarred up and scar tissue filled in that area. So our bodies are pretty amazing when you start to understand the different processes that it does all the time that no one knows about or they just take for granted until they stop working. When they stop working is when you realize all these different processes in the body, like this cup of coffee. Resetting. I got 5 in the house right now. Hey, what do you guys think about me changing my thumbnail like I've been? I'm doing that just for the live stream so I don't confuse too many people. I've been out for an hour and 24 minutes. Boy, I'm not sure it seems that long. Okay, so let's talk about, so we talked about the meniscus. All I said for the last probably 15-20 minutes was all about just the meniscus. Isn't that crazy? And I'm sure I'm missing a ton of other stuff. I'm sure my anatomy professor back in the day, she was wonderful. I don't know where she probably still, I don't know if she's still teaching at Mercy College or she's still at Einstein University, but boy, she was awesome. Thought would be a great idea to have a separate thumbnail from your video and live stream. Yeah, and that's what I did. I started using different thumbnails. So the one last night, the one tonight, or the one today. So my live streams, I'm going to have different thumbnails for them. So one is kind of cool. I think it brings a new aspect to the channel. and then two, it does separate out your live streams versus your drop videos or your edited videos. So as well as it kind of can give you an idea, like if someone wanted to look at a specific live stream, you could say, hey, it's this thumbnail or it's that thumbnail. If the thumbnails are too close together, I can't really do that. So it's nice to say, hey, just look at the thumbnail, that's X, Y, and Z. I talked about that particular knee like today on that thumbnail. So that's kind of cool. And so let's talk a little bit about the ligaments of the knee. And we got a few of them. And so, as you can see, these are pretty close to probably the size of the ligaments too. I mean, where they start and where they end, what we call the origin and the insertion. They are on both sides. You have one on the outside, one on the inside. And then you have the two ligaments inside the knee joint. So the ones on the inside of the knee is called the MCL, or the medial collateral ligament. All right. You have the LCL, or the lateral collateral ligament, on the outside of the knee that goes from the end of the femur here to the fibula head. And then you have on the inside of the knee, you have from the femur all the way to down here at the tibia. And you can see even the shape of this tibia from the back side. You can see how it's weirdly shaped. I mean, this one size knuckle is not even close to the same shape as the one on the outside. And you can see how much those menisci have to do, as well as the shelf of the tibia has to be up with these weird shaped looking knuckles. Now, the ones on the inside, the PCL and the ACL. PCL stands for posterior cruciate ligament, which is the one on the back side, and the ACL, the one on the front side, the anterior cruciate ligament. Cruciate meaning cross, but I've talked about this in the past. When you look at it, if you looked at the knee from the front or the back, the ligaments look like they do cross. But in reality, when you look over the top, they actually don't cross each other. They don't cross. They actually look like this. They are kind of like side by side a little bit. They're kind of not quite a triangle, and they're definitely not parallel with one another, and they're definitely not perpendicular to one another, but they're kind of like this, kind of a weird angle. And so when you looked at one way versus the other way, they look like they cross, but in reality they don't. So it's a misnomer, cruciate meaning cross, but they've kept the name. And so what do they do? What's the design? The one on the inside, the medial collateral ligament, keeps the knee from going outwards or this way. The one on the outside keeps your knee from going outwards, so it allows stability sideways because of just how this design is. The ACL, or the front one, the anterior cruciate ligament, keeps your knee from sliding forwards, or what we call translating forwards, and the PCL, the posterior cruciate ligament, keeps your knee from sliding backwards on itself. And so you keep this nice displacement forwards and backwards equal with these ligaments and where they're at. Now you can get them thick, you can tear them, you can rupture them. Now the main one that we talk about is the ACL. People get a football accident or car accident or runner falls or someone falls, you know, you get that translating forwards, you can get a rupture of that ligament. A lot of time, and you're going to cause everything else is going to get inflamed and irritated. But that's not going to heal. Within the knee joint itself, it's got synovial fluid, and that's it. There's no blood within the knee joint itself. Blood actually destroys cartilage, and so you would not want any blood within the knee joint itself. So it's nourished by synovial fluid, and the synovial fluid in reality isn't as good as repairing as blood flow is. And so the ACL, when it gets ruptured, it needs to be replaced. And so they can do a graft, all right, from a donor, or they can do it from yourself. If they do it from yourself, they used to do it from the hamstring. You can have a hamstring yourself. That's a part they could use. It's not as strong as the patella. They'll do part of the patella here, the ligament itself down here. This is the tendon. Most people think the whole thing is a tendon. No. The quad muscles coming down, attaching to the top of the knee, that's the tendon. From the bottom of the kneecap to the bone here, that's your ligament. And so they'll take a big chunk of that, and they will take a bone part out, and they will fashion that as your new ACL. And so they'll fix that. Now, that's if you're young. Now, technically, you can live without an ACL. If you're not going to go back to skiing and jumping and running and all this other stuff, or what we call plyometric type movements, you can live without your ACL and be fine. You're going to have a little more translation forwards than you would normally have. The other reality is you probably will wear out your menisci and the cartilage a lot more if you're not careful, especially if you start gaining more weight, because you're going to get a lot more movement within that knee joint, and the more movement is going to wear on those parts quicker, and hence you have to have a probably maybe a cartilage tear or something like that, or arthritis much sooner than you would have had if you had the ACL done. You can blow out your medial collateral ligament, the inside one. You can rupture it. If you're braced in one spot and someone hits you from the outside and just blows that knee out, that's easy to do. You can have a rotational component and blow that MCL out, as well as the meniscus. You can tear your meniscus at any point, whether it's the ACL or the medial collateral ligament. You can easily tear any part of the meniscus, whether it's the front part or the anterior part, or what we call the posterior part, or the posterior horn. You know, they call it horn of the menisci. They have certain names for it, depending on what we're talking about. The other part of the menisci that I didn't talk about is you have blood flow in certain parts of the menisci, certain parts you don't. The outer part of the menisci has blood flow to it. And then in the middle of the menisci, as you're coming in towards the center of the knee, you have kind of like this zone where you have partial blood flow, and then there's a zone where you absolutely don't once you get on the inside, where it's all nourished by synovial fluid. There's kind of like three zones to the menisci when we talk about blood flow and no blood flow. It isn't just blood flow and no blood flow. There's kind of like this zone where there is and where there's not. And so if you tear part of it that has blood flow in it, hopefully it heals itself. You don't know any better. But if you tear the other part that doesn't have any blood flow to it, you're in trouble. You're probably going to have arthroscopic surgery. Now, if you're young enough, they'll repair that menisci. If it's like what we call a radial tear, which means is that you have kind of a tear within it itself, like this. You know, it's not what we call a bucket handle where the tear comes over the top and the femurs catch, but it's basically a tear within the body. And so what they can do is they can sew the two ends together. They'll make you non-weight bearing for 6 to 8 weeks while that heals, and then you're good to go. But if you're older and it's in the inside part where there's no blood flow, they're probably just going to do meniscectomy, where they're basically just going to trim back that meniscus, and you're going to be left with, you'll be left with a meniscus, that isn't catching no more, but reality is you're changing the mechanics of stress forces on that knee joint once you start taking part of the menisci that was there, but it's damaged away. And so you're going to, you'll be fine, but realizing that you're going to have arthritis earlier in life than you would have had if you never had the meniscus tear in the first place. You guys have any questions? It's been like lights out here for probably me babbling for the last 15 minutes. I think I got 5 in the house, or I did at one point. Let me go ahead and reset this. I got 4 in the house. Person left. They fell asleep or left. I don't blame them. I tried not to make this boring. That's the reason why I make my edited videos, because this stuff can get boring very fast if I'm just doing instructional based, because that's what kind of like this live stream is. All right, Runny. BET's just listening. Do I have an hour and 30 minutes? I have an hour and 30 minutes. I think I'm going to call it for now, guys. I got to go do a bunch of other stuff today. I got to watch some more videos. I got to watch BET's video and stuff like that. Thanks for you guys all coming. Much love to you all. This was my first live stream, my first raid. And also I got to start thinking about making my video on Sunday. So that's coming up real fast since today's Friday. And all I've done is partially scripted it. So I haven't done anything else. I got a lot to do. Oh boy. Alright folks. We'll see you next time. Well, maybe you can blow up some pictures and just put them on the screen and talk about them. Yeah, I could do that. Like my video back here. Yeah, you want to love that green screen, don't you, BET? You want me to get that green screen. You want me to get that green screen. You need me to get that green screen. Oh, where's that from? That movie is from... You remember where that's from? You'd know, starting making different slides with colors that you can display. That's a point. Well, yeah, I mean, the green screen would do that. I mean, I got time this weekend. If I can, how quick I can get my video done, I might spend some time, maybe go to Lowe's and think about getting that green screen idea going. I mean, I'll probably just have a piece of wood and have it in the background here. Maybe I can hang it up and put a flat green board across it. So, yeah, put on here an app you are using. You should be able to put up the pics and videos. Yeah, I can do it through OBS. I don't think that'll be a problem. I can green screen OBS. I haven't done it yet, but I'm sure I can figure it out pretty quick. Yeah, that shouldn't take me very long. I mean, I'm already throwing up one of my videos on the media part, so I just have to make my video smaller and not do the video because there's only so much view space. I mean, yeah, I could edit a video. That would be more work. I could edit a video and play it in the background. I could do that. That would be easier, or just as easy as doing a green screen. That would be easy. Cut and paste, edit a couple of different videos and stuff like that. Yeah, that way you can use your mouse and point in detail or show other human pictures. Yeah, or I could just kind of, there's a delay. Even though, I don't know why, there shouldn't be a delay, but there's still a good 10 or 15 second delay, even though there's not supposed to be, between me actually pointing it out and you actually seeing it on your end. There's still a little bit of a delay. But then you can put it up over you and explain, gives more texture. Yeah, definitely gets more texture. Yup. Only downfall is you will have to use the computer more, but still, we be good for us to watch. Yeah, that's true. I think I would. I mean, I'd move the screen and stuff, so I'm still viewing. Instead of you seeing the side view, you'd still see me probably from this angle. So I'll have to work around it a little bit and see how I can do that. All right, I'm gonna go for now, guys. Thanks, BET. I gotta go watch your video.